Assalamu alaikum wa rahmatullahi wa barakatuh. The title of my presentation was a joke, but Nizar put it. He put the first title was Cases of the Old Days. I don't know what he meant with that because I was his teacher and he wanted to imply that I was an old lady. Then I told him, and then he put this title for me. So I present my first case, and he gave me some names so I can. Instead of using some volunteers, he gave me the names of the fellows and some of his residents. So I'll start with my first case because of the time. My first patient is a 37-year-old patient, female, a mother of 3 children, presented with the following complaint of recurrent fever of 3 months duration. They're different on both sides or the same? The same? Okay, but I have it on the slides a different, okay. Her fever was high grade, ranging from 38.5 to 39.5. It was for 3 months, recurrent, associated with night sweats and chills and rigors. It characteristically occurs when the onset of her menses. It breaks after the end of fever of her menses. The first episode, she received Augmentin, and her temperature recurred 3 weeks later with the onset of her menses. The second episode also occurred with her menses, and she received Sulfaxime. And the third episode again occurred, and she was admitted to a local hospital for a few days, and she received at that time parenteral antibiotics. She did not know what was that. She also complained of menorrhagia of the same duration, but no abdominal pain or vaginal discharge. There was no associated dysmenorrhea. There was also fatigue with the fever, with sweats, and she received antipyretics. But she denied any history of cough, sputum, chest pain, shortness of breath. There was no burning micturition, flank pains, or hematuria. There was no abdominal pain, jaundice, nausea, vomiting, no joint pain, stiffness, or any complaint. She also denied any weight loss, anorexia, bone pain, or swellings, or any skin lesions. She also denied any history of contact with febrile patient, any insect bites, no drug abuse, illegal sexual contacts. She travels 2 weeks prior to her onset to Egypt, and she had perineal repair, and the surgery went well with no complication. No similar illness in the family, and her social history was she's a non-smoker, non-alcoholic, and she was not using any drugs. System review was unremarkable, and she did not have any complaint. On physical examination, she was a middle-aged female woman lying in bed. She was not in any distress. She was not in any distress. She was conscious, alert, oriented, time, place, and person. She was febrile with a 39.4 degrees centigrade. Her pulse was 104, normal respiratory rate, and normal blood pressure. Hands, head and neck, and chest were normal. Heart examination was also normal. Abdomen again was normal. Liver was just palpable. The spleen was not palpable. And the liver span was normal. Vaginal examination was done by the gynae, was normal. There was no discharge, and there was no collection, and no evidence of any abnormality. Lower limb again was normal. There was no signs of DVT, and CNS was grossly intact. So this patient presented to us with fever, recurrent fever, high grade, admitted for further investigation. So now I can, Selma. Any consideration? You have 1 minute. Catamenial fever, differential diagnosis. Catamenial, it comes from the word, the Greek word that means monthly. Maybe the fellows can help you, Suad. No? Hanan, طيب Hanan. Turkestani, no? Somebody, he told me, gave me Turkestani. 2 weeks after the surgery. But the gynae examination was completely normal. There was no collection, there's no... Excuse me?
You have to do further images for him to know the repeat collections. The examination can go back to...
So you're considering a collection in the... okay.
This is the first thing in my mind.
Okay. حنان تركستاني صح؟ catamenial fever. Any idea? The fellows? Actually, when I admitted this patient, I was thinking of endometriosis. I thought I'm looking for endometriosis somewhere that is because of recurrent fever with the menses. And that's what I was looking for actually in this patient. Unfortunately, it was supposed to be an interactive session, and we were supposed to have our, but it is not in the, we were not able to get the ايش يسموه الماشين هذا اللي the voter. So the first thing I was thinking of is actually is the extrapelvic endometriosis. So when I admit this patient, I was looking for endometriosis because it occurs with the menses. So this is the first thing I was looking for, and when I admitted this patient. Stress-induced fever, okay. Any other suggestion? You are absolutely right. Familial Mediterranean fever can be precipitated by menses. Anything else? Anything else? Neisseria with menses? Okay, yes, but being recurrent for 3 months is a bit... it was just recurrent for 3 months. For 3 months with the menses.
Did they forget anything inside after when they did the surgery?
She was examined by the gynae and there was no... yes? Anything else? So familial Mediterranean fever also can be precipitated by... we have something called periodic fever with aphthous stomatitis, pharyngitis, adenitis. Although this is a disease of children, but can occur later on in life, and usually can be precipitated again with menses. And there is reported uterine tumors that is precipitated again and can be reported to be fever can be again reported with menses. You have anything to say?
Maybe not.
Okay. Why do you think of its?
Because it's current every 2 weeks.
It is with menses, with the menstrual period.
Who said menstrual fever? Where are you from?
Pharmacy.
No, you are from Saudi Arabia. So when did you go to hospital? You were in December, huh?
Yeah.
Okay.
Go to Egypt. She went to Egypt.
Also with menses, you can get recurrent herpes.
Current herpes.
But I don't think it will explain the illness. But it will not explain the whole systemic manifestation. But with menses, some patient who has got human herpes virus, herpes simplex virus type 2, they will get reactivation.
Okay.
If you are asking me, I will go for number 2.
Number 2, familial Mediterranean fever. Although she denies any history of joint pain, any abdominal pain, there was no any other symptom except fever. She had only fever with her menses, and she also complained of menorrhagia. Actually, I also thought of other diseases like Bill-Epstein fever, that is Hodgkin disease, and it was only the menses. I thought it was just a coincidence, yes? I will show you the investigation. She was non-neutropenic. Okay. And of course, this is, so this is the, this is the uterine tumors and less commonly condition that is related to catamenial fever, like some hormone-related fever that is again from the gonadotropin-related hormones, and this is again from the literature because of and again less common conditions. Again, this is very confusing, sorry. And this is poop-related conditions that occurs with menses. Bronchiolitis obliterans, organizing pneumonia related with menses. And this is the poop. Okay, so condition that is precipitated by with menses, actually there are many, including DKA, migraine, multiple sclerosis, paroxysmal supraventricular tachycardia, rheumatoid arthritis, asthma, many, acute appendicitis. The incident of acute appendicitis increased with menses. I don't know why, but this is what I thought. This is her investigation. Her white blood cell count was normal. Differentials, a little bit, again, it was in the normal side. Hemoglobin was normal, although she complained of menorrhagia. Her liver function test showed a little bit in elevated SGPT and elevated LDH and GGTP. Normal renal function, and of course the urine analysis, because she was menstruating, red blood cells, and there is red blood cells in the urine and increased ESR. At those days, this patient I saw her in 2006. We were doing Brucella and Salmonella agglutination titer. They were negative, and blood culture repeatedly was negative. Chest X-ray was done, was normal. CT scan of the chest, abdomen, and pelvis was normal. And so I was looking, as I told you, for endometriosis. This was my concern at that time. I was looking also, I was worried about Hodgkin disease, and I thought of this as Bill-Epstein fever, and this was also, no, there was no evidence of lymphadenopathy. The liver was just on the upper limit of normal, but there was no evidence of any lesion in that chest. So the patient stayed 4 days in the hospital. She spikes in the range of 38 to 20.5. After 4 days of admission, without any treatment, her fever remitted spontaneously. She was reluctant for any investigation, and she was discharged home. I gave her an appointment in 3 weeks, and she came back to me with the time of her menses, and she was again febrile with 39, and she was admitted at that time. Again, when I saw her at that time, I don't know if you can see that, but her white blood cell was normal. And if you see her liver function test, when she became afebrile, it slightly improved. But when she came back again, her LDH again increased. And this is when she came back again. This is when she became afebrile. Her LDH improved a little bit, and GGTP. And when she came back again, her LDH and GGTP increased again. So what would you do next? What would you? Our fellow? What would you do next? What investigation?
How old is she?
She's 34. What would you do next? Any suggestion?
Liver biopsy.
Liver biopsy, okay. ID? Liver biopsy? Nizar? Halim? Huh?
I will depend on your clinical sense. Yeah.
No, I will not tell you my clinical sense. I will not tell you my clinical sense. Huh?
DNC.
DNC? No, she was evaluated by the gynecologist. We did an ultrasound of the pelvis, and she was normal. It was completely normal. It was not, so we did not do a DNC.
How many children does she have?
She has 3 children. هعيد لك الهيستوري دكتور. وتحن تقولي تايمز اب. تحن تقولي تايمز اب. تقولي تايمز اب. قلته أنا. Trial of colchicine. إيش هتسووا؟ Hepatitis? We did hepatitis screening, was negative. We did the immunoglobulin, was no, it's on the upper limit of normal, but nothing is completely high. Excuse me? Autoimmune study, we did not do autoimmune. We did ANA, it was negative. And I did consultation to the rheumatologist also. Thyroid function test was negative, was normal. Blood culture was repeatedly negative. Psychiatry, she's febrile. I documented the fever in the hospital. She's in the hospital febrile.
You know, if you consulted the psychiatrist, what will he say?
He will say, I'm crazy. He will say, I am crazy. He will say, I am.
You will say you are crazy, and he will say that has stop our menses.
And that's in that paper that the gonadotropin dependent hormone, they actually stopped her menses because it was a hormone. So what I did actually, I did a bone marrow culture. I did a bone marrow culture because she received multiple antibiotics, so I did a bone marrow culture. So I did a bone marrow culture for this patient. So which diseases may cause fever to relapse? What do you think? Typhoid fever, will it cause fever to relapse? Yes or no? Yes or no? Yes, okay. Tuberculosis? Yes or no? Yes? Brucellosis? Yes? Visceral leishmaniasis? Yes or no? Visceral leishmaniasis? Yes, yes. So yes, yes, all of them.
No.
Yes, actually. No, to relapse. So, so actually, all of these diseases are causing fever to relapse. And it's interesting that all of these diseases cause fever to relapse. Tuberculosis have been reported to cause fever. In this paper from Spain, 3 patients were reported to cause fever to relapse. And the duration of the timing of the afebrile period from days to weeks, and he reviewed the literature, and there were 17 patients that they had fever that it relapsed, and again the duration of afebrile period actually from days to weeks. So, and again we have some condition that may cause fever to relapse, and this is commonly we see in children again, as Dr. Hana said, cyclic neutropenia, the fever, adenitis, pharyngitis, hyper-IgD syndrome, lymphoma, and this is the commonest things. And this is, again, as I told you, this is mainly, you see it mainly in children. So what I did the bone marrow culture. Fortunately enough, there was no malignant cells, and there is no malignancy. And the bone marrow culture, what do you think is the most likely diagnosis in this patient? Now, do you think it's tuberculosis, brucellosis, typhoid fever, or lymphoma, or syphilis? It is one of these. What do you think? TB? TB? ايش؟ TB? TB 2. Hassan? Brucella was negative. Serology was negative. TB? TB? Banat? TB? Okay. The Brucella culture grew, this blood culture, bone marrow culture grew Brucella. The positive blood culture found in 15 to 70%. The Malta girl were positive. Prior use of antibiotic reduced the enzyme positive blood culture. The presumptive diagnosis of Brucella can be made with serology in conjunction with a compatible clinical presentation. And this is usually what you can see in brucellosis. The positive result in Brucella, of course, we all know that it's usually with serology. But remember, the serology is not 100% positive. It usually, in a series from Dr. Mimish, when they have 160 bacteremic patients, 150 had Brucella serology. 3% of them, they have negative serology. Also in our series, where they have bacteremic patient, our bacteremic patient, three of our patients, actually they have negative serology. Few months later, I've seen a patient, she was Egyptian, she had the same complaint. She had fever with her menses. This patient, she was required several admissions to the hospital because she was Egyptian. Nobody thought of brucellosis, but fortunate enough, this patient's serology was positive. The minute we did serology for Brucella, it was positive. I've seen two in one. So why in what happened during menses? I tried to review this for you. I can't see it very well in this. What happened definitely during menses, CD4 count diminished. There is conflicting report between the natural killer cells and the interleukin cells. Interleukin, sorry, and the other cell, which is, I can't see it very well here, which is the killer cells. But the CD4 definitely increased during menses, and there is a conflicting report with the killer cells. So the final diagnosis is brucellosis. My second case is abdominal pain with fever. This is a 15-year-old patient. He's a student admitted with chief complaint of fever of 1 week duration. He has also abdominal pain of 5 days duration. His condition started with fever associated with pain, chills, and rigors of 1 week prior to admission. He also complained of generalized body aches. 2 days later, he started to complain of pain in the left upper quadrant. It was dull aching in nature with radiation to the whole abdomen. The pain increased with movement and partially relieved with rest. No history of nausea, vomiting, change in bowel habit, no other symptoms with that. He had appendectomy 5 years later. There is no history of sickle cell disease. He was never admitted to the hospital. There is no family history of sickle cell disease. He's not a smoker. He's not a drug abuser. On physical examination, he's a young male patient. He was febrile. Otherwise, his vital signs was normal. No lymphadenopathy. Chest examination was normal. Cardiac examination was completely normal. There was no evidence of any murmurs. Abdomen, the spleen was palpable. He was tender in the left upper quadrant. And the liver was just palpable, but normal span. There was a negative shifting dullness. Lower limb was normal. His investigation showed a normal white blood cell count, normal hemoglobin, and he had a shift band. Probably he was also sick enough with that. And he has also elevated high ESR. So, a left upper quadrant pain. This is not a usual complaint. Actually, I have to look it up to find for you the differential diagnosis of left upper quadrant pain. Probably we can use some of the Lulwa. This is a fellow. One of the students, Hatun, or a resident, Hatun. Who's Hatun? Hatun, yalla Hatun. Left upper quadrant pain is not a usual complaint. Usually you hear more of a right upper quadrant pain. Left upper quadrant pain. Left upper quadrant pain. It's not a usual complaint. What's the differential? Left upper quadrant pain. Tender, yes. So what does it think? Splenic abscess, excellent. What else? Lower lip pneumonia, very good. What else? He's giving you splenic infarct, very good. Splenic infarction, splenic abscess, acute torsion of the wandering spleen. Although this is usually pediatrician see, but sometimes we can see it in this age group. He's 15 years old, so he's considered more of a pediatric age group. And sometimes we have idiopathic paniculitis of the mesentery. This is, I also had to look it up. It's a cause, sometimes it causes pain in the left upper quadrant. All right, okay. So, and again, acute sequestration, this is we usually see in patients who have sickle cell, and that's why we see commonly among our sickle cell patients. Splenic abscess, of course, is very common among infective endocarditis, Staphylococcus bacteremia, Salmonella, ovarian septic vein thrombosis, and extension from adjacent structure. And this is his chest X-ray, CT scan. And as you can see, there is splenomegaly, and there is low attenuation in the spleen, multiple low attenuation area in the splenic area, and this is the spleen, and you see it's enlarged with multiple attenuation area in the spleen. As you can see it in this area. Okay, because of the time, how many minutes do I have? I have 3 minutes. I will not show you the differential diagnosis of the أعطيني time. You have so what other investigation would you consider in this patient? What other investigation would you consider in this patient?
Echo, yes.
Echo, yes. Anything else? What you consider? So he has multiple infarction of the spleen. Multiple infarction in a young male patient.
So you do an echo.
I do an echo. Anything else?
EBV serology.
EBV serology. He's helping you.
Yeah, PT and PTTs.
PT and PTT. You're answering the questions.
He's not a sickler.
He's not a sickler.
For the sake of time.
Okay. So lupus anticoagulant. Bone marrow aspirate. You want to do that? I don't think so. All right. So these are the So these are the following causes. Remember, atrial fibrillation, EB virus infection, oral contraceptive, severe liver disease, malaria, varicella zoster infection. All of these are causes of splenic infarction. So except for herpes simplex. Herpes simplex is not reported to cause splenic infarction. So this patient, EBV virus antibody was negative. His lupus anticoagulant was negative. His PT was normal. PTT was normal. Sickle cell was negative. So splenic infarction, again, we see it commonly among sicklers. And this is a study where they had a 10 years experience when they look at sickle cell, at splenic infarction. And they look at the causes, and you can see mainly it is it's either atrial fibrillation, antiphospholipid syndrome, thromboembolism, oral contraceptives, cardiac valve surgery, or severe liver disease. And sometimes it can be seen in diabetics, ischemic heart disease, chronic obstructive pulmonary disease, congestive heart failure, and sometimes it's seen in healthy individuals without any other chronic conditions. So although 8 patients were diagnosed previously healthy, 3 of them were diagnosed actually as bacterial endocarditis, and 2 of them with EB virus infection. So again, this is the, so why in infection they get splenic infarction? It's either hypercoagulable state in the rapidly enlarging spleen, in the case of acute infection, in either a malignant or non-malignant hematological disease. Okay, so what further management should you do for this patient? What should we do for this patient? Any suggestion? Any suggestion? Dr. Ali, any suggestion?
You need to go where the money is. So
Where the money is. What shall we do?
So if all your tests are negative,
So,
you will need to know what is happening in the hospital.
so what do you want to do?
I'm not the malaria smear.
You don't want to do a malaria smear. You want to repeat an EB virus?
No, not really.
You want to do hemoglobin electrophoresis?
Yes, maybe.
His sickle cell test is negative. Even though? You should live in the eastern province. Brucella agglutination titer. We like Brucella. No, he's Saudi. Okay, so what do you want to do? All right, splenic infarction be reported with all these conditions: salmonella, infective endocarditis, splenic vein thrombosis, EB virus, CMV, malaria, varicella zoster infection, Brucella, babesiosis. I had to review this.
You did a bone marrow, didn't you?
No, not yet. We did not do a bone marrow. All what we did is CT scan, and we did the blood cultures, because he was febrile, remember, and we did, so we did an echo. We wanted to look for endocarditis because we were worried that they had a thrombus, and this is just. So blood culture was positive. What do you think is the diagnosis? Is it salmonella?
How many say salmonella?
Salmonella?
How many say Brucella?
Salmonella? Salmonella? How many say Brucella?
How many say Brucella? Okay, 1.
How many says infective endocarditis? Infective endocarditis.
Come on. endocarditis, huh?
هتكون ايش اذا؟
You cannot say infective endocarditis. You have to say strep, for instance.
Okay, it was Brucella. It was gram-positive. It was Brucella again, growing from the blood. And okay, then Brucella was diagnosed from 4 cases in the world, causing 1 from Turkey, 1 from Spain, 1 from Italy, and 1 from Tunisia. as causing splenic infarction. And the fifth one is from Saudi Arabia, from Khobar. Thank you very much. And that's what I meant. Sometimes you have common diseases with uncommon presentation, so you don't have to always to have the common presentation of common diseases.
I'd love to say, to tell me about Rosetta in the Egyptians, because why
This is a Saudi patient. This is Saudi. This is Saudi. Saudi patient. The first one is Saudi. Yeah, of course. The second patient, I told you, I had the second patient few months later with Egyptian, the same complaint with menses. But this is the first one with Saudi patient. Okay, you have any questions? Thank you very much.